Good morning, everybody, and welcome to this little session that we have going on. As she said, Jo cannot be with us today due to illness, but Helen is a star in her own right, so we're very thankful to have her here. I'm just trying to get her to relax. So thanks, Helen, for joining in, and we'll just jump straight in. So as we said, today we're going to talk about transforming the pre-assessment into a digital pathway. A little bit of background for Northumbria. Northumbria were a paper-based pre-assessment to start with, so that's how we're going to transform. We went live in 2021. Yep. It feels like a long time ago, but not that far. And Northumbria are quite key in the sense that they are spread across a huge geographical site with multiple hospitals in turn. And Helen herself has to manage that, and it's not the easiest job, I'll have to say, admit, watching it, definitely. So we'll jump right into looking at what it was like before, and that's what our key is today. So hi, Helen. So let's jump into triage. Triaging. So that's where we started, really, wasn't it? Looking at the triaging. So pre-digital, so doing your paper assessments, the triaging challenges. Could you just walk us through what faced your trust before you went digital? So what was your pathway like before? How were you getting patients through onto pathway decisions? What were the sticking points for that?
So, as you say, it was quite difficult before, and very paper-based, very spread out across the whole of Northumbria. We had a small amount of paper-based triage happening, but we're very dependent on individual outpatient clinics being engaged in this, and we found that one particular group was very good in the gynae department, where they would fill out this small questionnaire with a set of observations, and we would triage that very basic information. And we did find that we could stop some patients from coming. We classed this as screening them out, and some patients just required a telephone. So we knew it was possible, but to roll that out in a much more broad and successful way was quite a challenge, being paper-based. So moving across to the digital format has made that a much easier process. So without that in place, we were very much dependent on the secretaries requesting a pre-assessment appointment in a timely fashion. It was very sporadic. Everybody worked in different ways, and everybody got an appointment. And then they would arrive in your clinic, and you would find that maybe half of those patients could have either been telephoned or screened out had we had that information in advance. So that was another driver to moving forward to digital, so that we had the opportunity to triage people early in the process to make sure they had the correct kind of appointment.
And I know Jo can't be with us today, but we have spoken previously with Jo, and in Colchester, they had a slightly different approach in the paper-based process, where they actually did put someone out, patients in Colchester, to create a one-stop shop, technically, to start getting triage. That worked really well, which is what you're finding with the digital system in Northumbria as well. But what happened was COVID hit. And then what we found with COVID is actually even processes that were working quite well with paper have now had to morph and change, because you cannot get that amount of people in a room, and you're having to look at different ways of getting that information out, which paper obviously gives a restriction on. Just wanted to throw Jo's little point into that as well. Were you finding that not all the patients, so you already said about half of the patients, didn't you, that came in for a full pre-assessment, you could have probably screened out. Are you still finding that post-COVID?
To be honest, the numbers aren't where we thought they would be. We thought we would have screened a lot more patients out. And it's hard to really define why that is, because we're finding a lot of patients who come are really highly complex, haven't been managed well in the community over the last 2 years because of the COVID restrictions. So where you would maybe have someone who has a controlled asthma, they might not have that now because they haven't had the input, or you haven't got the data to look in that GP record to find the information you need. When we would triage, when we set up the triage clinic, we had it that everybody in the team took a turn, because it is a skill that you want everybody to have. But we've now really narrowed it down to a small group of nurses who are doing the triage, so that we're all doing it consistently in the same way, and that has improved our screening out numbers. So I think that is something to think about if people are looking at how they're going to work that triage in the future. But everybody does dip in so that they can do it. So I think probably what we've seen is an increase in the telephone appointments that we have, which again is a real bonus for patients, because they can take the call at work. We can see them do the telephone assessment at the beginning or the end of their working day, so they're not taking time off work and having to travel a long way to our hospitals, because as you say, we're a very large geographical area. But the added bonus is through triage, we're seeing patients who actually need to be seen, because prior to this, the clinics were just full, and then we had this constant, we need this patient pre-assessed before next week, so the nurses were always seeing extra patients, whereas now we pretty much stay within the clinic template with the odd overbook as and when it's needed, so the staff are more satisfied from that. And also when we're seeing them earlier in the pathway, it's just allowing us much more time to pre-assess them in a safer way, because you can request the assessments that you need, for example, an echo. You've got time to chase up information from other trusts. If you need advice from an anaesthetist, it's just much more timely. So there's bonuses with that as well.
Was it quite a challenge to create a high level view? So when you had your paper process, what was it quite difficult to create the high level view? So people phoning down, asking where a patient was in a process, things like that.
It was very difficult, because we still had paper notes for everything at that time. So our paper notes were held in a facility off site, so none of the hospitals had easy access to it. So if I was asked an inquiry about a patient who'd been through the pre-assessment process, I was very much reliant on the nurses keeping records in a paper diary, or trying to work things out, looking at blood results myself and things. Or you would have to request the notes to be pulled from the library, which could take 48 hours to arrive. So that was very difficult and very clunky. It wasn't consistent. Nurses kept different records of things in different ways. So this is very much standardized. I can open anybody's record from wherever I am and see what the outcome of the assessment was, what stage, if they're awaiting it, and investigations or results. So it's much, much easier. And the secretaries in our contact centre have access to it as well. And the pharmacists have just come on board with it. So it's getting used by a lot more people than we'd initially anticipated.
Really good. So moving into the digital systems now, you've gone through some of your key differences in your process, but collaboration and communication across that multidisciplinary team seems to be quite a key thing. Like you said, the pharmacists have started to come on board. What about like other staff and wards and anaesthetists and things like that?
Yeah, so the end users, as we would call them, the anaesthetists who are looking after the patient, the ward staff who are admitting the patients, or the day unit staff, they all have access to the report from Synopsis. So again, they're not relying on notes coming from who knows where else in the trust. So they have easy access to that. But looking at, say, even how the appointments are booked, when a secretary requests an appointment, before the contact centre staff book it, they will look into Synopsis to see if there's a triage outcome for that patient, or if they're awaiting triage before they book it, so they know they're booking the right kind of appointment for them. And if a patient's still awaiting triage, they'll send me a message and I'll do that there and then. So again, we're doing the right thing at the right time. our admin staff use it so they can deal with minor inquiries. The secretaries, again, if they're wondering where their patients are, if they've, say, had a cancellation and they're looking for someone to slot in, they can look into Synopsis to see if there's a patient who's ready to go. So that it's been utilised well.
And that kind of comes into that streaming and efficiencies that we really would want you to get on board. When we've previously met with quite a few trusts, they say that clinically you can streamline your sales quite quickly because it's in your control. It's more the operational side that needs to be worked out and figured out a bit more. So what things in the hospital have you seen changes so you can streamline these patients?
Again,
and what needed streamlining?
Yeah, so the streamlining for me is making sure that the right patient's having the right kind of appointment, so that the appointments are properly utilised. We're not seeing patients unnecessarily, and again, not making them travel on like long distances when they don't need to. And I think the contact centre find a lot of satisfaction in being able to dip into Synopsis, so they're not continually sending emails to ask questions. So it's quicker and slicker for them. And I think for the secretaries, it just helps them manage their waiting lists. We've changed a few of the processes on the back of this as well. We've changed how we book patients in, and how long patients can wait before they've been admitted and what have you. So I think it has been a catalyst for other changes.
What about when new staff are coming on board? Because I know quite a lot of people that I met during our implementation and go lives, they were already looking at retirements, and they've been brought back for COVID and things like that. So you had quite a large amount of staff that you probably needed to be replacing. How's that gone?
It's been very helpful, and we were very lucky that our trust recognised the need for succession plan because of the retirements that were approaching, and we had quite a large recruitment drive last year. And I would say 100% Synopsis made their induction and training much easier. The consistency of how they practice, the way they ask their questions, the way they manage their workload, as in waiting for results, emailing consultants, all of those kind of things. It's very consistent. And the feedback from the staff was, once they got their head around it, because it is a new way of working, they love it. And even our staff who you say who'd been here for a long time, we had staff who'd been pre-assessment nurses for 30 years and knew nothing but paper and found it very, very difficult. We'll acknowledge that. They quite quickly said, actually, we love it and we wouldn't go back. So I think it is ride the storm, because it will get better. And it is just a lot of it was the IT techniques people had. I mean, I had limited IT skills, so it was just really getting back down to basics and making sure people knew how to use the actual IT to its full ability, and then the rest sort of fell into place.
And to finish our discussion before we move into Q&As, can you name what the biggest benefits you've experienced to go digital? So what's the biggest things that have come out for you?
I think one of the biggest differences and benefits is that the patient can be part of the process. We very much try and encourage our patients to start the questionnaire while they're in outpatient, so that they can complete the set of obs, because that helps our triage process. And if for any reason they can't do that, the patient's issued with the QR code or the web address, so they can fill it in at home. And they've got time to do this with the support of friends or family. And it means that they are owning that part of that care, and they feel involved, and we find that they're better informed when they come in. They'll come in with a list of medication, they'll come in with a list of questions. It's a more sort of controlled appointment. We find that it flows better. So I think that's a big bonus. Again, that thing of it being consistent, everybody's doing it in the same way. So if somebody, for example, is off sick and they've got things outstanding, it's very easy to dip into their work to say what needs to be done, rather than trying to go through notes and interpret what they might be looking for. And for me as a manager, it's just so much easier managing such a diverse trust and having access to have all this information as and when I need it. I mean, yes, you do sometimes need to back it up with phone calls, of course, that of interactions are appropriate, but I can make a lot of decisions without actually waiting for somebody else to answer a question. And you know, the fact that if a patient comes another time, you can copy forward information rather than writing it all out. You can cut and paste out of some care and HIE, so that saves a lot of time. And I know we're building into the new version where we can do links into leaflets, and you know, it just has so many options to it. And I would say on the whole, it's all positive.
Good to hear. So thank you for your time. And I think we'll now open up for Q&As.
Yeah, thank you both very much. Thank you very much, Helen, very insightful there. So yeah, just to put it out to our audience, really, if there's any questions that anybody has, if you could either raise your hand and we'll come to you directly, or if you can pop a question into the chat for us. Again, I've had a couple come through to me again personally, so I will jump onto them if there's no other questions, but we have. So let me just quickly check here. So Alison Weir-Smith, thank you very much. So Alison asks, hi, what is your demographic for your area, please?
In terms of the type of patients we see, right? I mean, we see all elective patients having a general anaesthetic. So we would be looking at ranging from bowel resections, spinal surgery, hip replacements, through to carpal tunnels under general anaesthetic. And the area we cover is from Berwick down to North Tyneside and across to Hexham.
Alison, you've got your hand up if you want to turn off your mic, if that answers your question, or to converse with Helen.
Yeah, hi Helen, there's a couple more things I'd like to ask you, and hi Tori, because I remember you from doing a synopsis presentation before. So I was just looking at when I was asking about the demographic as to how many patients you see. So as in a day, how many patients do you see in a day with synopsis compared to how many patients you saw before you had synopsis? Because we have the same problem here. We have a very slow process because it's all paper driven. I, for one, am absolutely pro synopsis. It makes sense to have something that is patient led, put into place. But I just need to know, you're saying that you're managing your general anaesthetics, and I'm presuming your regionals as well. But yes, what's the number of patients that you're seeing now, before and after?
Off the top of my head, I don't have all the numbers, but what I would say is a full-time member of staff will see 24 face-to-face and 2 telephones a week. And then obviously if the part-time, it reduces. We came, and it's the same number as it was before paper, but what we find is the nurses finish on time, they get their breaks, it's much more controlled and they're much more satisfied. And we came to that number. I did have to job plan the day so we could establish that there was protected time for the caseload management. And where there is any gaps in the day, because sometimes we're lucky enough to have empty appointments, the nurses will do triage. So the day is utilised. So I hope that answers the question.
No, thanks, Helen. Does that mean then that the nurse seeing those patients, she manages, or they manage their own workload for that week?
Yeah, so each nurse has their own clinic code, and the patients are booked onto their individual clinics. And then we do it that way because if somebody's off sick or they're on holiday, it's easier to cancel that one session. And we have it set up as a template where there are allocated appointments for joint replacements. We have reserved appointments for colorectal and breast patients. We do have some one-stop appointments put in that run alongside the breast clinic and colorectal to see if we can capture them in real time again, because they are quick turnaround patients and we're looking for a better experience for them. But yeah, they manage their day.
That's really kind. Thank you so much for answering that. Thank you.
Thanks, Alison. And again, thanks, Helen. So I'll come back. There's another question in the chat, but Emma, we'll come to you first if you want to ask your question through.
Good morning, Helen. Helen's
Hi,
one of my neighbours. I'm also one of the pre-op leads up north, and I've just recently started with NHS England and GIRF supporting pre-assessment processes across the country. And I think one of the things that is fed back into that platform is very much around the trusts who maybe have an electronic EPR system within their trust, and how that integration of a digital platform works within. And I think it's probably more of a comment, but I think for me it's a no-brainer having self-patient questionnaires, and we want to involve them, just as Helen's articulated, along with all of the problems that I think every pre-op lead has in the country. But really the question is around, from a timing point of view, how, when you're a trust who's got an electronic EPR and you can access that information, what is the advantage, and how does that Synopsis system then potentially integrate and quicken up the process, if that makes sense?
Yeah, so it starts really early for us. So when a patient has completed the questionnaire in its triage, this generates a daily report of what the outcomes are, and that goes to our contact centre, who will then book appointments from that list. So it happens within the week. We obviously still get patients who are booked via the secretary, and that can be for a number of reasons. Not all patients fill out the questionnaire, being the main one. When we're relying on the secretaries doing it, again, they work in different ways, and some of them are really efficient, get the request in early on, and others it's like 2 days before. So we will always have that, but we are working on processes with our secretaries to work differently. So it means we can see patients really early. Our pre-assessments are valid for 20 weeks for our trust. So if a patient has an admission date, the contact centre will book it in a timely fashion. If they don't have an admission date, we have anticipated admission dates, and they will again book it around about 12 weeks before, so we know that it's going to be done in time and there's some flexibility of it to roll on past the anticipated date. It's not perfect, you know, things change all the time, but it is much better. I have to say, it's much better. And we've now, sorry, Tori, I was going to say, we've now actually gone completely paperless or paper light. So our Synopsis report gets directly uploaded into MediViewer, which is our paperless documentation, and it's just so much easier.
And I would say, obviously, I'm a product owner, but for us, Synopsis is, we've got a pre-op team that specifically work on Synopsis, which is focused purely on pre-assessment and the perioperative pathway. And we don't just work with Northumbria, we work with a huge range of customers across the whole country and world to make the best pre-op that we can. And I think if you've got an EPR, your pre-op in that is a very small segment within a very large coil, very large cog, and having a specialized product that actually works with a pre-op team to utilize what a pre-op actually needs and collects, and the data and the algorithms. And we didn't get Joe in today, but Joe is very much about the rules and the algorithms and using them to create best practices. That's a big thing that's being pushed as well from the Royal Colleges back into our products, about making decisions but based on data, not just feeling as well. Obviously there'll always be clinical decisions, but it supports with the SORT score and the PPOSMs and things like that into the process. With regards to linking into other products, like Helen said, most of our customers take PDF summaries, which we're always trying to make those better, so it's very clear what information's a risk. But there's also the ability to take data. So we have another hospital who uses the data out of Synopsis to populate their waiting lists in real time.
Lovely, thank you both so much. Right, I've got a couple of questions in the chat that I'm going to come to first. I know there's some hands up, we'll come back to them. So we've got Pauline West here from Wirral University Teaching Hospital, asks how long is the allocated appointment time per assessment, and has this also altered since you've started this new way of working?
The 45 minutes, and it's still the same, because we didn't want to feel that we were just rushing patients through just because we had the digital questionnaire completed. And we also found, because of the triage process, the patients who are coming in are those who actually need to come in, and they have more complex needs. So they would have taken longer anyway. So we find that it works really well, because you have got some time saved because the questionnaire is there for some patients. And then when the patients haven't completed it, we do ask them to do it in the waiting area, and if they can't, we'll just bring them in anyway. So you do need that time protected, both because of the complexities of the patients coming through, because of the efficient triage process, we do need that 45-minute time.
Thanks, Helen. Chris Caldwell asks, how do you find uptake amongst the older patients? Hang on, I'm not finished, but
Okay.
there's more questions that have come in, so it's flicked. So yeah, how do you find uptake amongst the older patients? And do you provide a non-digital alternative, or do you force them down this digital route with friend help, for example?
It's pretty good, especially since COVID. Everybody, I think we all became a bit more proficient in IT. I'd never heard of Teams. I'd never done a Zoom call before COVID. And a lot of people can do that. If they can't do it, the information we give the patient, it says if you're unable to do it, just get in touch with the contact centre and we'll book an appointment. People aren't disadvantaged at all if they haven't got the IT skills to do it, or the equipment. They would just get a normal appointment if they're unable to do it. And if, like say, when they come into the outpatient area, when they're waiting to come into pre-assessment, we have got the iPads available, and our admin staff will ask if they can do it, and they'll start them off with the first few questions. We normally find once they know how to do it, they can get through. But those who can't, we just take them in and do it as normal.
One of my favourite things was during our Go Live week in, well, it was Alex that did it. And this little lady said, oh no, I don't do digital. And Alex went, oh no, she didn't say that, sorry. Alex went out and she was feeling like this patient's going to say no. So she went out, hid the iPad behind her back and said to her, oh, how are you going? How's COVID been? Oh, have you been doing that online shopping? Yes, all getting on. And then she whipped out the iPad, went, you'll be fine with this then. Like she had no choice. It just, yeah, it sometimes it's about taking the fear out of it. Yeah, in a supportive way. But yeah, they're not disadvantaged at all.
Okay, I'm going to come to a hand up. Nicola Swindlehurst has a question.
Hi, apologies. I'm on a computer that hasn't got a camera today, but it's been really interesting and really helpful. I've got a few questions actually, so stop me if you think that I'm going on a bit. But I think from what you've said, you haven't currently got a main electronic patient record system. Is that right? So the whole hospital.
Yeah, the whole hospital uses MediViewer.
Ah, right. Okay. So the input from Synopsis, is that in the form of a PDF, you said?
Yeah.
So that doesn't feed into your main EPR. So your alerts and allergies and things like that, you'd have to put in separately to a separate system.
Yeah, we would still put them into PAS.
Sorry, I don't understand.
Patient.
Administration system.
Yeah.
Okay. Okay, so that's like our electronic EPR then, so I understand that. What type of patients actually only need a telephone appointment? I'm really interested in that.
So they might be patients who haven't fully completed their assessment, of not sure on a lot of things, and then when we review that GP record through summary care or HIE, we might think, well, actually, there's very little in this record, and they might be having a minor procedure, so we would put them for a telephone assessment. And if during the assessment the nurse thought, actually, you do need to come in, they would complete the telephone assessment and arrange for them to attend for any additional things. Brilliant. Or it could be that a patient has noted a couple of things, like say they might have asthma, but they're not actually taking any medication. So you might just want to clarify a couple of points with them about that. So it tends to be those having minor procedures, ASA 1 or 2, under the age of 65. Okay, lovely, thank you. Roughly how many, I know you've said how many a nurse sees a week, but how many patients overall would you see? Fine. Sorry. Over a year, I don't know, I looked at this the other day, I think over the year. Can I come back to you that? Well, yeah, if you that would be really, I just need, I personally would love to know. I know that I roughly, my team say roughly 250 a week, so about 1,000 a month. And I don't know whether that's actually realistic or not, or whether, you know, because we are under the same sort of pressure as you are, so I completely understand that. And my very last question, how do you actually get to see them earlier in the pathway? What's your secret? Because I can't get that. And it doesn't work every time, but I think it is engaging the patient as early as possible, as in when they're in outpatients, or they leave outpatients with the QR code or the web address and say, fill it in when you get home. And then we triage that early. As a backup, when the secretaries type up the dictated information from the consultation, the synopsis details are included on that as well, where that asked, if you haven't already completed, please do it now. Yeah. So it's trying to get people as early as possible. And we do get a good uptake. I mean, some weeks, you know, you come in on a Monday morning and there's about 140 to triage. Brilliant. It varies quite a bit. I've just looked, we have 300 face-to-face and 31 telephone appointments a week. Lovely. Thank you so much. I only know that because I looked at it this week. Thank you.
There we go. Thank you, Nicola. And again, thank you, Helen. Again, a couple more questions and we'll finish it off. And I think if anybody does have any additional questions, please do just feel free to email us through to the team and we'll filter those through to Helen and Tori as necessary. Another one from Alison Moore-Smith, and she's just asking a really good question here. Is Synopsis reducing the need for patients being referred for face-to-face and aesthetic clinic reviews?
Yeah, I mean, the triage helps with that. Sometimes we'll triage patients in real time to go into the consultant clinics. We'll have another pathway for the highly complex patients where the surgeons have a set of criteria that we would ask them to follow, and they would email, we'll have a consultant inbox, and they would email a referral to them. Again, very early in the pathway, and on the whole, those patients don't get an admission date until they have been pre-assessed. So in terms of the nurses seeing the patients and then the patient requiring to actually physically see a consultant afterwards, it happens rarely, because that history taking is so thorough and so consistent. There is that trust there that the consultants have in the nurse's ability to take a thorough pre-assessment, and often they will just make that decision based on the assessment along with all the other information available to us through GPs and clinic letters. And then if they do need to see a patient, it usually is just at the end of that clinic because it's just a couple of points they need to review.
Last one is actually more of a comment, and again it's from Emma, who we've had a question from already, your neighbours. She has had to jump off, and she just said that she'd be interested to see some of the data, Helen, on the team freeing up the resource and its usability in those trusts with an existing EPR. So she will be in touch, but again, that's really valid information. And again, if there is any ask from our audience for any of the details, please again do just get in touch with us after the session. So I
We
think,
do-
oh, go on.
We do have a presentation. Our wonderful Band 7, who's much more IT literate than me, has put together a presentation, which I can share with Tori, and then that can go out, and it talks about the positives and the challenges, and I think it's just a really helpful way of pulling things together.
Absolutely. Thank you so much. We can absolutely attach that with the recording of the session, actually, when we send that out, if that's agreeable to everybody. So if there are no more questions, I think I'll give another 30 seconds or so. Well, no, maybe not quite that long, but if there's any other questions or hands up, now's your chance. No, I think we're good. All right. I think time to say thank you both so much. It's been invaluable, really. It's really, really great, insightful session. So thank you. And thank you again to everybody else who has joined us.
Bye-bye.
Take care.
Yeah.